Hello, everyone. A warm welcome from the Australian National University here in Canberra. I hope you and your loved ones are keeping safe and healthy. My name is Dipti Talaulikar. I'm a hematologist and the program lead for the Global Peer Support Program at ANU. Joining me are my team mates, Isabel Yam from Singapore and Jay Poria, both of whom look after international relations and partnerships here at the ANU in the areas of sciences, health, and medicine. I'm delighted to also have a medical student volunteer with me, Devashi, who's helping us behind the scenes. Our speaker for today is Dr. Amrita Varma. She's an emergency physician from Melbourne, and I welcome our panelists both from Australia and from India. From Australia, we have Dr. Archana Thota, or Archie, and from India, we have Dr. Shalini Pandya, a physician from Ahmedabad, and Dr. Sunil Chajwani, a consultant intensivist from Karamsad. Before we start, I'd like to acknowledge the Gunawal and the Gambri people, who are the traditional owners of the land where ANU is located and where Jay, Devashi, and I are broadcasting to you from today. And I pay my respects to the elders past and present. Many of you are joining us from various parts of Australia and the globe, and I would also like to acknowledge the traditional owners of all those lands and pay respect to the elders past and present. We've got the housekeeping rules up there. All attendees have their video and microphones switched off. This helps to keep the sound quality clear and reduce interference during the webinar. We do encourage everyone to ask questions. To do that, please use the Q&A button at the bottom of your screen. And if you do not wish to be identified, you can choose to pose questions anonymously. You can submit your questions at any time during the talk, but the panel members will get to it towards the end of the talk. There may be some questions that will come up on your screen during the talk for polling. Please do select your preferred response to those questions and be assured that all those responses will remain anonymous. If you have any technical issues or questions after the talk, please email international.health at anu.edu.au, and we will try to assist you. Please note that the talk is being recorded. With that, I'd like to introduce our speaker for today. Dr. Amrita Varma is an emergency physician from Melbourne in Australia. She is experienced in pre-hospital medicine, trauma care, critical care medicine, and emergency ultrasound. A very impressive resume there. As part of her training, she completed the Emergency Medicine Research Course, a joint course run by Monash University and Alfred Hospital. Dr. Verma's career-long passion for teaching has seen her involved in multiple teaching programs, including mentoring and peer support for medical students during the COVID-19 pandemic through both the Monash University and the Eastern Clinical School. She mentors trainees for the Australasian School of Emergency Medicine and has created multiple teaching programs focusing on critical care. She has been involved in medical education and upskilling of junior doctors during Australia's preparation for COVID-19, and also volunteers telehealth services for the people of India through Global Medics for COVID Telegram service. Welcome everyone to the webinar, and with this I'll hand over to Dr. Amrita Varma.
Hi everyone. Yes, my name is Amrita Varma. I'm an emergency physician from Melbourne. Thank you everyone for coming. So my talk today will be on evidence-based medicine in COVID, and my one sort of disclosure or affiliation is with Global Medics for COVID. So we're a volunteer group of Australian and New Zealand doctors who were providing help through a messaging group on Telegram to patients in India. And when we were helping a lot of people who were not able to get hospital beds or just had general queries about COVID, and seeing a lot of prescription or prescribing and therapies that we were questioning. And I thought that now that things are starting to wind down, it would be good to review the evidence to sort of plan for future waves, because unfortunately, as I'm sure we're aware, there will be third and fourth waves potentially in many countries. So I'm joined by my panelists. So Archie is a fellow emergency physician in Melbourne. Shalini, who is a consultant endocrinologist in Ahmedabad, and Sunil, who is a consultant intensivist and anaesthetist in Karamsad. So when I was researching this talk, it was interesting going back through the timeline. This was on the 29th of January, earlier this year, when India had just come out, or was hopefully coming out of its first wave. And the government had declared that India had successfully contained the pandemic. And it was interesting how quickly things turned and how quickly things can turn with COVID. I might ask maybe Sunil some of your experiences in the beginning as the pandemic started, what you were finding in hospital and just in life in general.
Madam, see, January 2020, we had COVID ongoing almost from last year. But then January 2020 was a phase when we had seen the least cases after the first wave got over almost. We had in our ICU out of 100, we had 20 patients. And I remember my duty was ongoing and suddenly we found a surge, in my duty of the 5 days when we get rotational duties, from 20, the patients increased to 60. So it was the end of January, we started seeing the beginning of the second wave. And it's quite evident, it went up till the recent, trend now. But it was the end of January and the beginning of February when we started seeing the second wave. And it was, this is the first time experience in my life, I've seen such a huge wave and every person in my, I can tell my hospital had helped us a lot, but all of us, we were in the great physical and mental stress to handle this, large volume of patients of COVID. It was like, a too stressful job for all of us in the terms of infrastructure, in the terms of, manpower, the shortage of nurses, shortage of oxygen, shortage of drugs, everything.
And I think it sounds impossible to beat at the time. And in that environment, I think it's really easy for a lot of misinformation. And, as a doctor, you don't even have time, I would imagine, to even look at the evidence or data because you're so busy trying to help the people in front of you.
So, madam, see, most of the people do follow the evidence-based practice, but I think the certain, the people who are at the GP, general practitioners, sometimes they do not follow the evidence-based practice, but I think the persons who are working in tertiary care center, they are aware about the protocols. And we have the AIMS body, the AIMS hospital, which, the governing body in the India who tries to frame up the protocols and they try to update the, the Indian doctors day-to-day basis, what the protocol should be for the local protocols, which will be suitable for the country like India.
So I thought that we would just take a quick poll at the moment. Just 3 cases which were similar to what we saw on the app when people were coming to us to ask for help. So the first one is this. And out of the list of things, these were all sort of things that we saw recommended for people at home and in hospital. So a 35-year-old woman who is previously healthy, no regular medications, who has tested positive for COVID and has had 5 days of fever, dry cough, myalgias, and fatigue. And maybe I'll just give 30 seconds if people can vote for what they would recommend. And then the next case is a 60-year-old man who has type 2 diabetes, hypertension, obesity, is on multiple diabetic and antihypertensive medications, who has presented with 2 days fever, cough, and some subjective shortness of breath, and is also tested positive for COVID. So again, out of the options, what would people suggest for this man? All right, and then the last case is a 45-year-old man with hypertension, obesity, and 7 days of fever, dry cough, lethargy, who is tested positive for COVID, and for the last 2 days has become hypoxic, is now requiring oxygen, and the family are unable to source a hospital bed. And unfortunately, we did get messages like this, not infrequently, on our messaging app. Okay, so are we able to have a look at those results? So for question 1, so a lot of simple medications, weight proning, dexamethasone, pretty spread evenly across the options. And option 2, the second case, are we able to have a look at that? Or is this a total of all 3 cases?
I think the results were shared at the time, Amrita. We can't go back to them again.
Oh, okay, sure. So I think it's a bit difficult with all three cases, but it looks like most people are sort of recommending simple medications and awake proning, dexamethasone, and then a few others with some of the other therapies. So my talk today is, where is the evidence for these medications, and where did some of the lack of evidence or misinformation come from? And how do you know when the evidence is actually there? So we'll hopefully go through what does the current evidence tell us, and then talking a little bit about trials and why it can be so confusing and why their results aren't always valid. So what is bias in a trial and how does it affect results? And also, what are our own biases that affect our day-to-day practice, particularly in a pandemic when, you know, that there is a lot of panic and we're all human beings and we're all affected by the same issues. And so what are some of our own biases in life and when we are making decisions? So I think I thought I'd start in the beginning with what we know has evidence of benefit. So dexamethasone, hopefully everybody knows by now. So was one trial, hopefully there'll be more, but the recovery trial. And it was a randomized control trial with over 6,000 patients. It was open label, which means that it wasn't blinded, but the recovery trial was actually a very well designed trial. And one of the benefits when you are able to design a trial and then prospectively recruit patients is you can actually control for a lot of biases that may affect your result and control for a lot of confounders that also may affect your end result. So because the trial was such a high quality randomized control trial, they were able to minimize a lot of bias and control confounders that really is not possible in a lot of the other trials that have come out. And what they found was that the overall decrease in mortality on hospitalized patients was 2.8%, which doesn't sound like much, but when you think about the numbers involved in COVID, so in India alone, there have been 30 million people, 300 million that have tested positive, I think, or 30 million. But the 2.8% benefit, mortality benefit adds up to tens of thousands of lives saved. And the greatest benefit was actually in the sickest patients. So in ventilated patients in intensive care, the mortality benefit was 12.1%. And in any patient requiring oxygen, the mortality benefit was 2.9%. So certainly when we were getting messages of people who were hypoxic on oxygen at home, one of the things that we recommended on the app was that they did start dexamethasone if they were able to get a hold of it. But I think one of the other issues is that when you have a treatment that works, you actually have to follow the protocol that is in the study. So the study actually, they gave 6 milligrams daily dexamethasone, and that's been spread to other countries, so some equivalent of dexamethasone. And the important thing to note is that it was for a maximum of 10 days. There was no increase in dose, and the dexamethasone was stopped when respiratory symptoms actually improved. So whether that was hypoxia or shortness of breath and work of breathing, in a hospital environment, I would presume hypoxia. And so not every patient needed it for 10 days. And the reason why I think this is important is because after this trial came out, or even before, there were a lot of patients receiving high-dose steroids, prolonged dose steroids. And then we found sort of the downside. So the risks here with high-dose steroids is immunosuppression. And what we're seeing in India now with mucormycosis. And I don't think that steroids are the only contributing factor. So most of the risk factors are really sick patients anyway. So those who are diabetic, already immunosuppressed, who have required an ICU admission, and who have had prolonged hospital admissions. But steroids have probably had a part to play in terms of the rise of mucormycosis. Sunil, I was wondering if you could comment on your experiences working in ICU and seeing mucormycosis.
Yeah, madam, actually we saw a lot of rise in the mucormycosis, especially in the second wave. So in the month of March, actually we started seeing the mucormycosis patients getting admitted also. And the ENT colleagues of the mine, they were almost seeing 1 or 2 cases per day in the OPD. And as far as ICU is concerned, we had 4 patients we had treated for the mucormycosis. This is, including cerebro, rhino, this one, rhinocerebral mucormycosis I'm talking about. And we actually were able to, get the 2 patients out of ventilator. One had extensive spread intracerebral and which presented very late. And we had mortality in that patient. But out of 3 we were able to get them out. 1 we had mortality because of extensive involvement and quite late presentation. That was a disseminated mucormycosis, I can tell.
Mm-hmm. Yep. And Shalini as well, you're an endocrinologist. I'd be interested to hear your experiences with diabetic patients during this wave and whether you've seen any mucormycosis.
Yeah, we did see in my private practice in my hospital, which is a Sterling hospital, a corporate hospital here. We had almost 30 cases of mucor this time. And we have actually published data, not me, but my ID expert has published in association with 3-4 other centers, and total number of cases are 208 plus. While in a civil hospital, which is a government hospital set up here, we had almost 500 plus cases of mucor. The important point in this is that not all of them were diabetic. 48% of them were found to be diabetic. The rest were on steroids. And I don't know whether we people in Western world part of India are more prone to mucor because we have seen more in Gujarat and Maharashtra. And the other thing I think is uncontrolled diabetes. It is considered, our part of India is considered to be a diabetic capital of India. So maybe that is another reason that we are seeing more. The important point this time was, last time what we saw was mucor following COVID. Patient was discharged and then the patient gets mucor. This time, even before discharge, we have picked up patients having mucor. So it's not exactly post-COVID. It's early this time.
Is that you've tested early? Is that
I think
looked for it early?
Yeah, it could be. And we actually were, all of us, apart from the doctors, even the patients are more aware. So each time a diabetic has a COVID, even if they don't have symptoms, they want, madam, please just rule out mucor, So I think we were more aware this time also. But more than that, I think this wave was really bad in the sense we had the severity of the infection was high. Patients went into hypoxia, happy hypoxia within 5th day. Last time it was on the 2nd week. So everything was very fast this time. Maybe that is the reason, we don't know yet. And steroids definitely have been used more often than not in our setup. And at times patients have taken them on their own, over the counter also, because in India they are available easily.
Yeah, and I think that was sort of the point that I wanted to raise is that that there is a place for dexamethasone and for evidence-based, but there are also side effects to all of these medications that patients are taking, and it can have a significant effect if it's not used correctly. So moving on to Remdesivir, which is the other therapy that has some proven evidence in COVID. So again, I don't want to go too much into detail in terms of the trial, but it was a well set up trial, which is why we can trust the results. So it's a double-blind, randomized, placebo-controlled trial. Hopefully most people know what those terms mean, but for those who don't, double-blind means that the patients and the doctors were both unaware of who was getting the treatment versus placebo. And it just, again, helps to minimize bias and confounding in a trial. So they gave 200 milligrams of remdesivir as a loading dose and then 100 milligrams daily for up to 10 days. They were not able to demonstrate a significant reduction in mortality, but they were able to demonstrate a reduction in time to discharge from hospital by 5 days. And again, in a devastating second wave like India had, when you are tight for hospital beds, this remdesivir does potentially have a role to play in hospitalised patients. So then one of the other things that was being done across the world, starting from the sort of very first wave in China, was this concept of awake proning. Awake proning has really began from proning therapy in ARDS, where it was found to have some mortality benefit in these really sick patients who are really quite unwell with ARDS. And the theoretical benefit was that it improves VQ mismatch, it can improve secretions, and can improve alveolar recruitment in the lungs. And in China's first wave in New York, when they had their wave as well, again, when people were running out of hospital beds or there was not enough oxygen, it became sort of a mainstay of treatment as a way to improve saturations. But the issues are duration. So in true ARDS, when you prone a patient who is intubated, they're prone for 16 to 18 hours a day, which is not always possible in awake patients. There potentially could be issues with tolerability and pressure care in intubated patients. And there was still no evidence out there that it worked. But there has been a review article that has come out this year. It's not a meta-analysis or a controlled trial, but it's a review of the literature with awake proning in the COVID era. And unfortunately, what the authors have concluded is that although there is a strong interest in proning for acute respiratory failure, we still have very limited evidence of its benefit in terms of mortality. They've mentioned that there have been some reported adverse events with awake proning, including nosebleeds, sternal pain, potentially pressure ulcers, and intolerance, which is probably the greatest sort of adverse effect. And we don't yet have the expected benefits that reduces mortality and intubation. The anecdotal information coming out from China and New York is that it does improve oxygenation temporarily, and that it can be used as a temporizing measure, and potentially some patients may benefit and may avoid sort of intubation or progressing to non-invasive ventilation. And again, I would be interested to hear from Sunil about your experiences in hospital with awake proning.
Madam, we used to actually, advise, recommend the patients, encourage them to be having awake proning, especially when they come, and they need oxygen. So like what we used to do is we always used to advise them, keep half an hour in the right lateral, then again half an hour in the left lateral. So they go on changing the position from the right lateral to the left lateral to supine to prone. So we advise them to do as often as they can do. So as much as they can do, we used to advise them. And most of the time, we used to recommend about 2 liters. Suppose if they need oxygen, we used to recommend this. Apart from that, we used to advise them incentive spirometry also to increase the FRC and vital capacity of these patients, apart from the chest physio. So yes, awake proning was definitely, we were following till now. And the same thing we used to follow in the patients who were intubated also. ARDS patients, COVID ARDS intubated.
And were you intubating, so were you proning the ARDS patients for longer periods of time?
We used to start them as early as possible because what we used to observe when we intubate them, the saturation used to fall dramatically after intubation due to Vicky mismatch. So like we were forced to prone them. We had to sedate, paralyze them and prone them to maintain the oxygen levels. Mm-hmm. So especially during the second wave, we found that moment the patient get intubated, the saturation used to fall still further down in spite of giving them 100% oxygen, optimizing the PEEP there. So the proning was becoming more of rather mandatory rather than optional to maintain the oxygen levels. That was the scenario we were facing this time.
Yep. And Archie, I think you had some thoughts on proning as well.
I think for me to have a flow chart in my mind as to when I would do awake proning. So awake proning in the really early phase where people are not hypoxic is not useful, sorry. And if they're mildly hypoxic requiring 1 or 2 liters, it's not really useful because in the early stages of COVID, when the lung compliance is really, really high, they could improve oxygenation when they are prone, but as soon as you make them supine, that benefit is lost. So it's useful in the ones where you need FiO2 of more than 28%. And so for 4 to 6 liters, or somebody who's on 6 liters Hudson mask is sort of who you look at proning. And I think that's a good cutoff to have in mind to whom to prone. There's definitely a benefit to trying to increase the time from when they're hospitalized to time to intubation. That way, when resources are poor, you can see if you can, utilize those resources much more beneficially. And I think when not to prone is also an important, when not to use the awake proning, but go towards intubation. So if somebody is hypoxic and they're not improving oxygenation with oxygen, then they're not for proning, they need to be intubated.
Yeah, and I think this review article it's difficult because there haven't been any trials, but it is free, the patients are awake, there are minimal harms, despite some reports of adverse events, and it has been shown to improve oxygenation. So as we were discussing, as a temporizing measure to see if it helps as part of chest physiotherapy in these patients who are requiring oxygen, I think there is some role, but hopefully there will be some more evidence that comes out in the next sort of year or so about whether it does actually do things like improve mortality or improve hospitalization or reduce the need for intubation.
So this is not evidence as in written evidence yet, but some of the discussions coming out of the US is when you have a really bad hypoxia, stiff lungs, hypoxia, not responding to oxygen, and even high flow nasal prongs or CPAP, simple CPAP, then not to delay the intubation at that point in time, and to actually intubate, not use proning as a bridging measure there, because it doesn't really benefit. You're having a high degree of hypoxia and brain injury from sort of delaying tactics from there.
Yeah, and I think it's just that always treat the patient in front of you, not the number. But we better move on, we could talk about that forever. So Ivermectin seems to be the new kid on the block in terms of the new wonder drug for COVID. And when I was researching this, I found a lot of interesting facts about Ivermectin that really sort of demonstrate the social media and misinformation and some of the issues that we've all sort of seen in terms of COVID therapies. So the initial study for Ivermectin was this. It was actually an Australian study by Monash University, and they had done some lab experiments, and they reported that Ivermectin eliminates COVID in cells within 48 hours. But I think the important part of this announcement is not so much what it announces, but the date. So this was done on the 4th of April in 2020. So China was battling its very first COVID wave. New York had just started, I think. Italy, had just started with their COVID wave. And this was very early in the course of the pandemic. There were no treatments available. We didn't have our oxygenation or intubation therapies. We didn't know what worked, that we were seeing really high mortality rates. And so there was a mad scramble to see what, if anything, works and where are our research opportunities. So these researchers did what researchers do, and they found a potential avenue. But even in their own study, they were very, they commented that, Ivermectin should not be used in patients. Further studies are required. This is purely a theoretical benefit. And so despite that, as I said, in April 2020, we were right in the middle of pandemic panic with no known effective treatments. So despite their warnings and the fact that it should not be used in clinical practice, there was uptake by multiple middle and low-income countries who then began claiming success from certain areas in medicine that they were managing to reduce COVID rates and deaths. But they were going off this study, and having a look at this study, we can see that, so what did the study do? They took infected cells with COVID-19 virus and they infected them for 2 hours. They added 5 nanomoles of Ivermectin, I think, and then they analysed those cells over 1 to 3 days. They then looked for a reduction in cell viral replication, and they found a 99% reduction. And so they reported success as a theoretical avenue for research in Ivermectin. And this was reported and then shared around the world through media, social media, and somehow it managed to get onto multiple countries' governmental guidelines that Ivermectin cured COVID. But there's always something missing when these sorts of things happen. And what they didn't report that was in this theoretical trial, the dosing was actually really high, 160 times what the FDA demonstrates as safe human levels of Ivermectin. And there was no real discussion when ivermectin was being broadly spread throughout countries of side effects. And in general, ivermectin is well tolerated. But there have been case reports in Africa where they've had widespread ivermectin usage for other reasons. There have been case reports of serious side effects like encephalopathy, coma, cerebellar dysfunction, blindness, and death. And this is independent of the underlying illness that the patients have been treated with ivermectin. And so one of the issues is that whenever we prescribe these medications that have no benefit, there is an opportunity cost. So an opportunity cost is an economic term, and it means the value of what you lose when you choose between your options or two or more options. And so one of the opportunity costs was this. So in order to prove that ivermectin is effective in COVID or not effective, you need to, again, have high quality randomized controlled trials. But even in last year, so many patients in Latin America were on ivermectin that they actually couldn't find patients to test and enroll in randomized controlled trials to prove that ivermectin did or didn't work. And so that makes life really difficult when you're trying to prove anything for this unproven therapy. In addition, in America and in other countries as well, there was a lot of people in the poorer parts of the country who had to resort to the black market to buy medications. And so there were people, and I'm sure this has happened in other countries as well, who were selling ivermectin as part of a cocktail of unproven therapies for much, much higher than you would normally be able to buy them on the black but on the black market, obviously having much higher prices. And in other countries and in India as well, we're now seeing that a lot of people desperate family members, who have paid for a lot of treatments, have now gotten themselves and their families into significant medical debts because of COVID and because of the treatments that were offered. And so one of the issues is that despite a lot of organizations like the World Health Organization, NIH, recommending against ivermectin, a lot of governments were still recommending it as part of their protocol. And so I think as a doctor, it's very difficult to not go with your governmental guidelines when it's actually part of your... Earlier this year, they came out with a meta-analysis. So this was ivermectin for the prevention and treatment of COVID-19 infection. So they said that they've created a systematic review, a meta-analysis and trial sequential analysis to change clinical guidelines. They've published it in the American Journal of Therapeutics. And reading through it, it's available for free online. You can Google it. Sounds very professional, and they claim that ivermectin has been proven to show a 68% mortality benefit. But when I was reading through this meta-analysis, I found a few issues. And I think that this is one of the problems, is that there's a lot of data coming out with people reporting on trials and meta-analyses and systematic reviews. But if you have an understanding of how to actually critically appraise these articles, they're actually quite problematic, and there are very few articles or trials that have high quality evidence. So they found their conclusion, they said that moderate certainty evidence found that large reductions in COVID are possible using ivermectin. But as I said, a few issues. So they did mention that they didn't find any large COVID-19 trials which were powered to detect a decrease in all-cause mortality. So they said that they made a pragmatic decision to power their meta-analysis on the pooled effect of all-cause mortality a priori. And what that means is they extrapolated and theorized on the reduction in mortality, but they weren't able to demonstrate that through any of the trials that they actually looked at. They mentioned a lot of technical terms, and they said that they chose the de Simonian-Laird method of analysis, and had a lot of words that, this is the most appropriate analysis to be used. What they didn't mention is that the de Simone and Laird method can be biased in itself, particularly where the number of studies is small and the heterogeneity, so the difference in the trials, is high. And lo and behold, the meta-analysis had a small number of studies that they looked at, and the heterogeneity of the trials was very high because they were taken from multiple countries. They had multiple different endpoints, and Ivermectin was used in multiple different parts of the patient's journey through COVID. So even their analysis methods were flawed. They also said things like, we consider blinding to be a less important criterion for evaluation of evidence, despite the fact that blinding is one of the most important features that we have in trials to minimize bias. And they also took preprint publications that had not been peer reviewed, and they said that we did not consider publication on preprint websites to constitute a risk of bias because we reviewed them. So therefore, we can vouch for their quality. And so again, reading through, I think that there's a lot of issues. These are just a few that I found, but if you read through the article and actually critically appraise it, there's a lot of flaws even in their discussion of the article. So this is just an example of some of the studies that they looked at through many different countries, many different trials. Looks very professional. So at the top you can see they've reported by country, what funding, sample size, the dose of ivermectin, and the main outcomes reported. But I think if you compare this to a proper meta-analysis, and this is the NIH guidelines on ivermectin, which again is available in public. The NIH is an American institution, and they have published some guidelines on ivermectin, and they've released a table looking at the studies that they've looked at, which is very similar to the previous meta-analysis. What the meta-analysis is missing is this. What they haven't mentioned in their meta-analysis is the limitations of the studies. And actually going through the studies, and I have no doubt that the doctors who started the trials worked very hard to gather their data, but they all had significant limitations. And what happens when you have limitations in your trials is that it limits your interpretation of the trial. So this was one of the trials that was in both meta-analyses, and the NIH guideline, looking at the evidence on balance and including a discussion of their limitations, said that they actually can't know the clinical efficacy of ivermectin. So again, coming back to this meta-analysis from the FLCCC, what they reported was that death from any cause was reduced with a moderate quality of evidence. But if you remember in the beginning, what they mentioned was that none of the trials were powered to detect all-cause mortality, which is another word for death for any cause. And yet this is what they have said has got a moderate quality of evidence. In the discussion, they don't really explain how they came to that conclusion. And if you'll notice, looking at all of the other sort of outcomes that they've looked at, the quality is very low. And so therefore, again, you can't really comment on ivermectin as a therapy because out of all of the other meaningful outcomes, we don't have enough evidence. Right now, where we're left with ivermectin is really the WHO guidelines and the NIH guidelines. And they've said that the current evidence on the use of ivermectin to treat COVID-19 patients is inconclusive, which is exactly the truth of the matter. And until more data is available, WHO recommends that the drug only be used within clinical trials. So I fully agree with this. I think that, and this is a sort of prime example of where a very, very small theoretical study at the height of panic of COVID was really taken up by a number of different countries and a number of patients without any real knowledge. And then the myth has been perpetuated, and we've seen these trials and meta-analyses and literature reviews coming out, which really don't add anything to the literature. Using this as a case example, I think that there are a lot of medications which have similar lack of evidence but have been used widely. Archie, did you have anything else to add to that at all?
From the ivermectin point of view?
Mm-hmm.
No, nothing to add. I think ivermectin is pretty much gone out of fashion. I've had family members in India who've been on ivermectin despite me telling them not to be on it. So it's a very commonplace for people to be on ivermectin, even just buying it over the counter.
And Shalini, I'd be interested again in your experiences in sort of dealing with outpatients, whether you saw people putting themselves on treatment or what you were seeing in terms of patients in the community.
First, let me start with Ivermectin. I haven't used it ever because the first data was from Bangladesh and had some 60-odd patients. I think you have also shown that data. And it was not a very convincing trial. Subsequently, we had another trial from Uttar Pradesh in India. Again, the control arm was not so good. So I have never ever prescribed in the whole 1.5 years of my practice. But I have seen patients being on that. And if I have told them, please don't take it, they have not listened because the next person, the next relative says, no, it's working.
Yes.
So in India, it's difficult, I think, again, because we tend to get our medicines over the counter. You actually don't need prescriptions most of the times, and which is very bad for the patient also. Apart from that, I think in the last 1.5 years in COVID, we have changed our practice from the personal touch to teleconsultations. So I would suggest that because of the first lockdown, we saw a first wave which started slowly. There was a plateau in September, October, and then a downfall around November, December. The second wave, according to me, Sunil Do says Fab, I would still say it would be 15th March around, mid-March, when we had those rallies and Kumbh Melas and elections and everything, cricket matches going on. And that's when we saw a steep rise in the second wave. And immediately it came down in mid-May, and by 30th May, after 30th May, I have hardly seen any new case of COVID. So this COVID virus is very unpredictable, and it not only humbled us as Indians, but I think we saw the same waves and same patterns in UK, in Italy, Spain, France, US, in Europe was bad of time. So everywhere the infrastructure gets overwhelmed. And because of the panic, I think people start using all different current kinds of treatments because we are not sure what's working. But I can assure you, Ivermectin is out of prescriptions, mostly in the second wave. And AIMS has also come up with our guidelines, which they keep on updating almost every month. And they have written Ivermectin, but they have also written that the panelists don't agree with. So I think there is some political clause to it. Apart from that, I would suggest that we have been using telephonic consultation. I have been using it very much. And we used to see almost 50-60 patients per day, personally also, plus in teleconsultations. And we used to triage them into mild, moderate, and severe, depending upon how they came. Patients were sent videos of how to deal with the virus, how to do a home isolation. And every daily, actually, they would send me their vitals. With the oximeter, they will check their saturation level. So at the end of the day, we would have the data of the day. And my diabetics, I had already told them to check their sugars twice a day, because we have seen almost 20% new onset diabetics. And most of the diabetics, even with the mild moderate, previous diabetics had hyperglycemia. And so we had to change their sugar values, their OHs. Or if they are on insulin, admitted patients, we had switched over all of them to basal bolus because of the high dose of steroids. The sugars were all over the place most of the times. That 85% of our patients were treated well in home isolation. And we did give steroids in some, even in home isolation. The second week where we thought the fever is again, which has come back, is because of inflammation, and it is not the infective or applicative phase, and the patients have done well. I think when I see my data, most of my patients, almost 68 to 70%, were managed at home. 15% had to go into ICCUs, not exactly ICCUs, but mid-level. And ICCU was just 4 to 5%. We have a mortality of 2% in my patients that I have analyzed till now. So I think more or less, most of the patients do well if you do good monitoring of them.
And certainly from the Telegram app that we were running from Australia, we had similar experiences. There were a lot of patients who were diabetic, a lot of patients who were able to manage at home, and some patients who were quite unwell and needed to be admitted to intensive care. We saw a similar sort of thing in terms of patients getting Ivermectin or antibiotics or antivirals over the counter and self-starting medications. And also, I think, some prescriptions from local doctors that maybe we didn't necessarily agree with. And I think the sort of learning point from Ivermectin is it's very difficult to retract the information once it's come out into the community. I don't really understand the motivations of this FLCCC coalition. They're all doctors, they should know better, but they really have pushed the Ivermectin case quite hard. But it's only the most recent of the medications. I thought that, in case you didn't believe my analysis or the NIH, so this is COVID guidelines in India. This is by the CMC Vellore with a number of other people. They have about 50 people on their committee who have done a very, very thorough review of all the medications with COVID. And again, they agree that the evidence is very, very low for any outcomes with Ivermectin. So the same story can be applied to a lot of other medications that have been used in the COVID pandemic, including hydroxychloroquine, doxycycline, azithromycin, and convalescent plasma. So in the beginning, when we had the poll, there were still some people that were recommending these antibiotics for patients with COVID or hydroxychloroquine. And what I would say is that there is absolutely no evidence of benefit in COVID or any use in COVID at all. So really, we're left with steroids and Rendezvous and sort of home isolation and awake proning. And that's what we have right now. There are some trials at the moment looking at proper high quality randomized control trials with Ivermectin, so we may see a change. And I think that's one of the things to remember with evidence-based medicine is that evidence can change, but you need to rely on the high quality evidence, not the sort of low quality evidence that is much easier to replicate.
Amrita, could I ask the panel members and you perhaps to go through the 3 cases that you had put forward? And what you would do, and then we might wrap up because we're getting to the end of the talk.
Okay, sure. So I'll just have to go back to the beginning. So it was, so the first case was a 35-year-old woman who was previously healthy with no other issues, and if we presume her vital signs are normal, then really all she needs is simple medication, so paracetamol and NSAIDs, and to be advised to continue to observe and watch for any increasing shortness of breath. Shalini, is there anything else you would recommend for this woman?
Yeah, I would like to know 2 more things about her. First thing is whether this lady is vaccinated or not. And second is the fever, whether it was low grade or if it's high grade. So we have 3 scenarios here. If she is fully vaccinated, has a low grade fever, I would not be worried. I'll just wait and watch with the standard care of therapy. And if she is not vaccinated, has high grade fever, I would ask her to get some blood investigations done. Would be CBC, CRP, D-dimers, ferritin, LDH, LFTs, RFTs, and blood sugars. And depending upon the results, I will decide my further line of management on that. If she is vaccinated and still has fever beyond 100, again, we will just get the blood reports done and then decide what we need to do about it, right? And if the CRPs are very high, beyond 50, 75, I would actually ask for a CT and maybe go ahead and start steroids in this, and Remdesivir if possible and if it's available, because in India, again, there's a shortage of Remdesivir. There was a shortage in the second wave, and Remdesivir, you have to admit the patient. We actually started home therapy for Remdesivir with steroids in such patients who were maintaining their oxygen saturation levels. So that is again a little dicey thing. So if you see the oxygen saturation of this same patient on the first day and it's around 99, and on the 5th day it is 94, that is that she is going towards happy hypoxia. Or if after 6 minutes walk test, the oxygen saturation is dipping by 4, I would still consider it to be going into a moderate to severe illness. So according to that, the treatment might change.
Sure. And our second case was a 60-year-old man with multiple comorbidities who had fever, cough, and subjective shortness of breath. So Archie, what would you recommend in this man, presuming that his SATs are normal but decreasing on exertion?
I think he's on the spectrum. So he's 60-year-old and he's got confounders being diabetic and obese. So I know he's coming under the high risk category for moderate to severe illness. He's already, if he's subjectively short of breath, quite often by the time patients are subjectively short of breath, they're usually hypoxic. And if that is the case, then he's getting admitted if there are beds. That's the problem is are there beds available in hospitals to admit this gentleman? And when it doesn't happen, then that's when people start sourcing their own oxygen. And then we have change of care from the usual evidence-based medicine to anything available.
And what would you suggest the evidence base would be for this man if he was desaturating on exertion?
Well, his standard of care would be dexamethasone, plus or minus admission if he's hypoxic for oxygen therapy.
And the third case is 45-year-old man who is hypoxic at home. Sunil, do you have any thoughts about recommendations for him?
Patient is obesity. He has 7 days of fever. Day 5, he has shortness of the breath. And the oxygen levels I can see is 80% on the room air and more than 90%, 4 liters oxygen. So definitely the 7 days have passed by. So he has passed the viremic phase. That's more important. Now, thing to be remembered here is why the viremic phase is important. Before we prescribe steroids, especially the oral steroids, we should remember that they need to pass this phase. There we get some kind of patients, madam, especially when I look at the first and the second case. They are the mild category of patients. If the second is a moderate, we have to look at the SpO2 levels. If the SpO2 levels are normal, we have options between the two. Whether to if the CRPs are rising trend, the patient continues to have high grade fever. So they are basically progressing toward the systemic inflammatory response syndrome, what we call cytokine storm. So in such cases, we should try to avoid steroid as much as possible within 6 days, because that can flare up the viremic phase and cytokine storm can get precipitated. Now, in our case, because the 7 days have passed by, the oxygen levels are low. So definitely here, the steroids will be indicated as per the recovery trial. Second thing, because the desaturation is there, he needs a hospital admission, and the remdesivir option can come here because he has comorbidities, and remdesivir should be given within 10 days, which is important. If in case we prefer to give remdesivir, it should be given within 10 days. Beyond 10 days, remdesivir has no benefit.
No benefit.
So after starting remdesivir and steroids, we watch for the clinical response. How are the oxygen levels improving or not? We watch the CRP levels, we watch the inflammatory markers. If clinically the patient is responding well, if oxygen levels are improving within 24 to 48 hours, there's nothing else to do. And the awake proning and all that thing, definitely yes. I'm talking about the more of pharmacological therapy I'm talking about. So if now the second scenario comes, if the patient doesn't improve in spite of giving remdesivir and steroid, and the CRP continues to go up, that's the time we have to take a call on the IL-6 inhibitor. So that's the time where we decide about tocilizumab.
Yeah.
And tocilizumab is a thing, which should be given early, preferably within 24 to 48 hours after ruling out contraindication.
Yeah.
This is the key home message I want to give.
And I think that obviously that's, for patients that need an ICU bed. One of the other things, just briefly, because I know we're running out of time, is just looking quickly at budesonide, because we also saw that being prescribed a lot. So an inhaled steroid. There is limited evidence, but if it is going to be used, it should be used in patients who have mild symptoms within 14 days, and they have COVID positive PCR test, and they're over 65 years or 50 to 64 with a comorbidity. And it's a significant comorbidity, so asthma, COPD, ischemic heart disease. And so we saw a lot of young patients being prescribed budesonide on the chat, but actually the indication is for the more older high-risk patients in the community. There is no evidence of benefit in sort of moderate to severe disease, but it does reduce symptom duration by 3 days, as self-reported by patients. Just because we're running out of time, I'm just going to talk very quickly. I will leave these publications up at the end. So there are some excellent review articles about bias in research and why you can't trust every research article that comes out. And the main sort of conclusions is that bias can occur at any points along research. If you have bias, the errors, these bias and confounders can cause fatal flaws in the data. And no matter how much you try and analyze the data afterwards, your data is not valid. And so that's been the criticism for a lot of these smaller studies, is that you cannot control for this bias based on the study method. So their results cannot be accurately analyzed. So they publish these graphs. And so they say the grey area is when Ivermectin has been started in the national protocol, but also roughly around that area is when COVID lockdowns, strict COVID lockdowns were introduced in Delhi and Uttar Pradesh. So I just wanted to just highlight that. And this is why controlling for bias and confounding is so important in research, and why it matters when you read a trial. Sorry, Dipti, I know we've gone over time, but I think we can end there if we need to.
Amrita, can I add something?
Yes.
So in the case 2, if you can bring that case back, the patient has metabolic syndrome basically, and it's a second day, right? And the saturation you have not mentioned, but there is shortness of breath. So in such patients, actually now we have monoclonal antibodies here, and this could become a good candidate for monoclonal antibodies.
So I think that the evidence in monoclonal antibodies is still being produced. I think that there are some trials ongoing at the moment.
Still in the trial. It's not in the guidelines. What I'm trying to say is we can enroll such patients in the trial and see how they do.
Yes. Correct. And I think that that's really important, that the correct patients are enrolled in these trials as well. So these are just some resources that I'm going to leave up here for evidence-based guidelines and how bias in research. I would say that the WHO, the NIH, and the American Infectious Disease Society of America have really detailed reports on evidence in COVID, and they've really methodically gone through the evidence that's out there, the quality of the evidence and the recommendations. So the ISDA, the Infectious Disease Society of America, you can Google, they've got a really good simple table, and it's sort of a stoplight system, green, orange and red, in terms of proven therapies, completely unproven therapies, or therapies that have been proven not to work, and then things that are under investigation and trials. And the monoclonal antibodies and the immunomodulators are all being considered in trials right now. All right, well, thank you, everybody. I think that's the end.
Thank you very much, Amrita. We know these are very dicey and difficult situations when you are facing patients on the ground. So there's no, and these are academic discussions that we have here. This is no judgment on any person or government decisions. Thank you, Amrita and panel members. Thank you, attendees.